And so the next segue to the next talk is standards of care and non-surgical treatment options. Trying to apply these guidelines to individual patients will be by Dr. Mary Mulcahy. She's an associate professor at Northwestern University. She is also a medical advisory board of Debbie's Dream Foundation, and she will give us her talk.
Great. Thank you. Thank you for having me. Thank you all for coming out. First, I want to apologize for my sniffles and things. I'm having a little allergy attack here. Bear with me. I will try to be as discreet as possible. So you've heard about staging and you've heard about the guidelines. And what I was going to try and do is show you what we're thinking. When we're sitting there in that office and what's going through our mind, how are we guiding people? How are we making decisions to guide people in the appropriate treatment for them? And this is, what you see on the screen here is a picture of a cross-sectional picture of the esophagus and the different layers, and this is part of the staging process. How deep is a tumor? You see a picture of the stomach, and we look at the same thing. How deep is a tumor through the wall of the stomach? And then there's where it all sits. It sits in a very high rent district. It's around the aorta and the heart, and right at the lungs, and going through the diaphragm. And it's in the stomach and the esophagus sit in a very complex area. So all of these things are playing into our treatment decisions. So when we talk about treatment planning, we're tying that in with what's the goal of the therapy. What are we going to, given the tools that we have, what are we going to achieve? What are we going to be able to achieve? So the tools that we have are chemotherapy, radiation, surgery, and certainly symptom management is a real important part for anybody with gastric and esophageal cancer. Managing someone's symptoms to give them the best quality of life and the best performance status so they can tolerate the therapy. And based on having these tools, what is our goal? Are we going to try and cure this disease? Are we trying to control this disease? Are we trying to make people feel better? All of these are reasonable goals, and there's a lot of things that play into this. The first one is the cancer stage. Cancer stage is part of our assessment. And you heard about this from Barbara. What is the stage of the cancer? And essentially we break it down into three main categories. We can get into, the T stage, the N stage, the M stage, and then stage 1, 2, 3, and 4. But what we're really looking at, is it a localized cancer? Is it locally advanced? Has it metastasized? And this is like the first step, getting to this stage of the cancer. This is the first step in our decision for what sort of treatment are we going to recommend and what is the goal of that therapy. So this is a picture of, this is a CT scan. And the CT scan, it's a cross-section, so you're lying on your back, and we're doing cross-sections like in a deli slicer. And in this picture, I think I have a pointer, we have the liver. Here's the stomach, and the nasty stuff they make you drink to outline the stomach, and a little piece of the spleen back here. And in this cross-section, we see this wall of the stomach is thickened. And that's the cancer. And this appears to be a localized cancer. On the big expensive radiology screen, you can see a couple of lymph nodes outside the stomach. So there's a couple of lymph nodes just in the nearby area of the thickened part of the stomach. But everything else looks fine. The liver doesn't look like it's involved. The peritoneum isn't involved. So we've got a localized cancer. So that's our first step. Where is the cancer? How far has it spread? What's involved? And for this particular one, it's localized. This is a different story. Here's a patient. Again, we see the liver. Here we see a little bit of the pancreas. But here is the stomach cancer, and it's extending beyond the wall of the stomach, and it's actually involving, it's adherent to part of the colon. So it hasn't spread to the liver, it hasn't spread to the peritoneum, it hasn't spread to the lung. It's still localized in this area, but it's extended beyond the stomach wall. So this one is advanced. This is a locally advanced tumor that hasn't metastasized. And we take that into account and figure out what is our treatment that we can offer this person and what is the goal of that therapy. What are we hoping to achieve? And here's another story. This is a patient with metastatic disease in the liver. The darkened spots are the metastases in the liver. And again, seeing this, we know that our treatment might be different. We may not be operating on this. Our goal of therapy will be different. So the first step that we look at is the stage to try and decide where are we going and what are we going to offer people. But that's not everything. So cancer stage is an important part of it. It's our first step. But we also need to see what kind of shape the person's in. What's their performance status? And you've heard that mentioned already today. That's a measure of how robust someone is. How much reserve do they have? What has this cancer done to them? And how much energy do they have left to tolerate these therapies we're going to propose? So the performance status and their general health status. You heard Barbara mention that this is generally, we see a lot of young people with it, but generally it's a disease of older people. And older people may have other diseases, heart disease, lung disease, diabetes. How are these going to play into their ability to tolerate these therapies and to recover from the therapies to have a good quality of life? So we look not only at the stage, but also the overall patient. For example, a stomach cancer in this 80-year-old gentleman might be different than a stomach cancer in this 80-year-old gentleman. Age isn't the only factor. What these other medical conditions and their performance status, how much reserve they have, all of these things are very important in guiding people for the right therapy. There's other things we look at. What sort of symptoms are they having, and can we reverse those? Can we improve those symptoms? Pain, most importantly. People who are in pain, they don't eat well, they don't sleep well, they're not going to get up and get out and be active. Pain control is an important part of managing these cancers. Nutrition. Nutrition, not only what are you eating, but are there other nutritional supports that we can use? Is this going to be possible? Is it because the stomach is too blocked, or is it just the cancer that's taking away the appetite? So all of these things are important parts that we need to try and control the best we can, and nausea and vomiting as well. There's another part to this too. What sort of support services do people have? You've heard a lot this morning. The caregiver panel was fantastic. Just what is involved in helping people with these diseases. It takes a lot of support. And if we're going to propose to somebody that they should have radiation, what does that mean? That means that they have to get back and forth to radiation therapy every day. And if they live on the third floor of a walk-up and they have to get up and down those stairs and back and forth to radiation every day, is that something they're going to be able to do? Is that a reasonable treatment approach for that person? And again, with nutrition, do they have somebody who can go shopping for them and provide them meals? Do they have access to Meals on Wheels? Do they have a feeding tube, and are they going to be able to manage that at home? All of these other factors are just as important. What sort of supports are there, and what can we do to improve that? And all of these factors play into helping us determine a therapy. So what is the goal of the therapy? Well, our hope is to cure disease. And when there's localized cancer, that's certainly the goal that we're going for. We're going to try and cure this disease. Somebody has to have a good performance status. If somebody can tolerate what the therapy that we're going to propose to cure the disease, we have to make sure that they're going to be able to tolerate it and to recover from it and reap the benefits of that cured disease, feel well, and have a good quality of life. It's our goal to control the disease. Maybe it's at a stage that we can't cure it, we can't eradicate it, but we can control it. We can control it, we can help them live longer, we can help them feel better, they can live their life, they can raise their children, they can do their job, they can do what's important to them. This may be because of the stage of the disease, or they might have a localized disease, but they just don't have the performance status to tolerate a big surgery and radiation and the chemotherapy and everything that's involved. Are we going to try and palliate symptoms? Is it a disease that is spread beyond what we can cure? They are not up for all the treatment, and what they want to do is they want to feel well. It's important to discuss this with people, what their goal is, what is important to them. If they have limited time, how do they want to spend it? What are the important things in their life? If they have complicated medical problems, are they going to be able to tolerate the treatments that we have for gastric cancer? So here are some examples that we'll go through. This is that first slide I showed you with the localized cancer. This is a 68-year-old woman. She's got some diabetes, but it's well controlled. She's had about a 5-pound weight loss. She's tolerating a normal diet. So she's got reserve. She's done okay. Her CT scan shows that there's no metastatic cancer, but there's this localized cancer. So our goal for her in talking with her about the stage of her disease, her overall health status, the goal is to cure this disease. And there's a lot of options. You've heard about the guidelines, and they are just that. They are guidelines. They are not rules. They're guidelines. They help us guide people on the best treatment, and there's options. It's good to have options. Sometimes there's different people who like to approach things in different ways, and that is okay. And so for something like this, some people will do an operation first. There's some people that say, get this out of me. I want to have an operation. And that's not unreasonable for a localized gastric cancer. After the operation, depending on what we find, it's likely that it'll be recommended that they have adjuvant treatment. Adjuvant treatment is therapy in addition to the curative therapy. The surgery is the curative therapy. The adjuvant therapy is a little insurance policy. It helps to improve the chances that you're going to eradicate any disease out there. And that adjuvant therapy might be chemotherapy. It might involve radiation. There are options. There's data to support all of these approaches. And we look at the data, we talk to the patient, we make a treatment decision together. It's shared decision making. Another approach for a localized cancer is to have chemotherapy first. Some people will do, some physicians like that approach, some of the patients like that approach, do the chemotherapy first and then have surgery. And that's okay too. As I said, there's data supporting all of these, so any of them are reasonable, and it's really a decision of what is the right thing for that person who's sitting in front of you, and for the expertise at the facility. Excuse me a sec. Okay. So here's another case. This is a patient with a locally advanced tumor. So this is a 36-year-old woman, otherwise healthy. She came in with some anemia, some abdominal pain, and she's had a 20-pound weight loss. And as many of you probably know, she was going to the doctor with these vague symptoms, some abdominal pain. Lots of things cause abdominal pain. Some anemia. 36-year-old woman with anemia is not uncommon. She started losing weight. She liked that idea at first, and then it became too easy. So she had a CT scan. It showed this tumor that's adherent to the colon and also, we thought, to the liver. So in talking to her, she was otherwise healthy. She was having some trouble with this. Our first goal was to get her anemia under control, get her pain under control, and get her in a good state where she could accept these therapies. Our goal was to control the disease. Can we get a response where we can operate on it and she would benefit from that? That was the question. But we weren't sure yet. So we started with a staging laparoscopy, and I'm sure you'll hear more about that, because one of the questions was, we see that this is more advanced. Is there more disease there than the scan is picking up? And peritoneal disease is tumor deposits outside of the stomach into the abdominal cavity. We can't see it on a CT scan. We can't see it on a PET scan. There's no blood test that's going to tell you that. Sometimes you just need the surgeon's eyes to look at it and tell us that that's what's there. They'll do a laparoscopy, they'll look for any of these nodules, and they'll help us decide, well, how far is this cancer progressed? So she had a laparoscopy, and there was no other evidence of disease. It was just this locally very aggressive tumor right at the stomach wall there. So we got her symptoms under control. She was started on chemotherapy. She did not go right to the operating room. She was started on chemotherapy, and she actually had a really good response. And she clinically got better. She was tolerating the chemotherapy, and ultimately we were able to do an operation. And they resected this bowel that was stuck to the stomach. They took it all out in one piece. She had very few lymph nodes that were involved. There were about 3 out of 20 that they looked at, and there was no peritoneal disease. So as of now, she's doing well. And when she walked in the door, we weren't sure. This could have gone either way. We weren't exactly sure how this would go, but given that she had the reserve and she had the support systems and she was able to tolerate the therapy, she did very well, and she had a resection and, as I said, is doing well. Let's look at this woman. This is a 45-year-old woman. She had no other medical problems, perfectly healthy woman. She has had abdominal pain, a 15-pound weight loss, nausea, vomiting, fatigue. She just wasn't feeling well. She ultimately underwent a CT scan, and they found this liver with tumor in it. She had a biopsy, and they tested it for HER2. So they tested for the protein. We have the drug trastuzumab that can target this abnormal protein, but her tumor did not express HER2. Most of them don't. She had a HER2 negative adenocarcinoma. Our goal for her was to control the disease, to prolong her life, to improve her symptoms. We weren't going to get rid of this. So we had to be reasonable with what our goal was and have that frank discussion with her that we couldn't get rid of this, but we can control it, and we had a chance to help her feel better. So as always, the first step is to control the symptoms. Get her feeling better, her pain, her nausea, her vomiting, get her feeling better first. She was then started on chemotherapy, and I wrote with a platin and fluorouracil, vague. I left it vague on purpose. There's a number of, this is the basis for most of our cancer therapy for gastric cancer. A platinum drug, cisplatin, carboplatin, oxaliplatin, they're all the same class. And fluorouracil comes in the pump that you walk around with. It comes in an oral form, but essentially a platin and fluorouracil is the basis for chemotherapy treatment for gastric cancer. And she was started on that, and she had a good response. Everything shrunk. She felt better. She started participating more in her kids' activities, and overall, she got a benefit from this. After a while, once she was feeling well, we stopped the platinum. The platinum drugs can often have some toxicity that accumulate over time. So we dropped that, and she was maintained on the 5-FU alone, feeling really well, and did well on this for about 14 months. And then after that, we saw that there was some tumor growth. We changed to a taxane therapy, the second line that we've learned from these clinical trials that you've heard about. And that's what she's on now, and again, doing well. So these tumors, we knew when somebody has cancer that we can't operate on, that we can't resect, it eventually is going to learn some trick around the chemotherapy. These cancers are constantly changing and evolving and growing, and they will mutate in a way that it's going to learn some trick around that chemotherapy. We go to the next one. And these days we have next ones. I'm on the NCCN panel for esophagogastric cancer, and it is really exciting when we have some late-breaking news with some new drug, and we all have to get together on this call and try and look at the data and figure out if it's going in the recommendations. And luckily these days we've had some advances like that. And we need to treat people in a way that they can gain the benefit of these new advances. We don't want to make people sick with our therapy to a point where they can't get the next therapy. So balancing all of these things are important. Now, if we change the story here, if this is an 82-year-old man, he's got coronary artery disease, renal insufficiency, he's had a 20-pound weight loss, difficulty swallowing, he lives alone, he's rarely leaving his apartment. He used to go out to the senior center and play cards with the gals, and now he's pretty much become homebound because of this cancer. And he's not swallowing well. He's got an obstructing esophageal mass. So our first goal for him is to improve his symptoms. And here's a picture of esophageal obstruction, and this can be a miserable symptom to live with. And if you look at the picture on the left, if you think about kinking a hose, and all the water going through is going to build up behind it, you can see that swelling up above, and then nothing can pass through. The middle picture is actually the barium going down a little bit, sneaking through this obstruction. The last one is a scope. Nobody can read them except for gastroenterologists. So what do we do with this? How are we going to make this guy feel better? Well, one thing you can do is operate. You can operate on an obstruction and relieve the obstruction. But if you recall, this patient has a lot of tumor in his liver. So anybody who knows somebody who's gone through a surgery like this knows what's involved. To undergo that big surgery and recover from that surgery, his liver tumor would just be growing during all that time. So that wasn't a good option for him. We could radiate it, and radiation can shrink this local tumor. But again, we're not doing a lot for the disease in his liver, and the disease in his liver is life-threatening. This is what's bothering him, but the liver is what's life-threatening. So we opted for a stent. So here's just an illustration of how these stents work. It's done by an endoscopy. First, they put a dilator through to stretch out this tumor area, and then they deploy this wire stent in there that just pushes the tumor aside. It doesn't do anything for the tumor. It doesn't treat the cancer. It's relieving his symptoms. It's giving him the ability to swallow, and that can improve somebody's quality of life significantly. So this gentleman had a stent placed, and he opted not to have chemotherapy. He decided he was swallowing better, he was feeling better, and he opted to live his life, and he knew he was dying from this. He had no family. There was a nephew who actually came to live with him, and he was enrolled in hospice care and died peacefully with an ability to swallow. So I feel like we did something for him to improve his quality of life, even though we weren't able to extend his life. So the last case I want to show you, this has to do with the guidelines. This is a PET scan. So you've heard about PET scans. This is a young gentleman. very robust, very healthy. He had difficulty swallowing. He underwent an endoscopy, and a tumor mass was found at the GE junction. And he had a CT scan, and we didn't see any other disease. So it was looking like this was going to be operable. So we got a PET scan, and in this case, a PET scan can be very helpful. If you're thinking about operating on someone, a PET scan may identify some lymph nodes that might change that plan. So the PET scan, or it can change it the other way. If you see enlarged lymph nodes and the PET scan is not identifying those lymph nodes, maybe they're from something else. So for people who are having potentially resectable disease, PET scans can be very helpful. And this PET scan shows us this tumor down here at the GE junction. But then on a further one, you can't see it too much, but there was something lighting up all the way up here in his neck, the supraclavicular lymph nodes. And he underwent a biopsy of this, and it showed that the cancer had indeed spread beyond the GE junction up into the neck. If you look at the NCCN guidelines on this, it'll say that this is not a resectable tumor. And we talked about that. We talked about our treatment options. His tumor was HER2 positive. He was started on chemotherapy. It was his decision after this discussion that he didn't want to have this big surgery, have his esophagus removed, with the chances that cancer was going to come back. He wanted to know if there was an alternative to that. And we started on chemotherapy with trastuzumab, with Herceptin. He had an excellent response. The tumor responded very well, and he was on this for about 1.5 years with this tumor responding. And I kept talking to him, I'm like, well, maybe you should talk to a surgeon. Maybe this is one that we should operate on. And after a couple of years of good control of disease, he did decide to talk to a surgeon, and we radiated the esophagus, we radiated the area at the lymph nodes, and he had an operation. At the time of the operation, there was no detectable disease. It doesn't mean there's not cells out there, and he knows that. Luckily, he did well with the operation. He's maintained a good quality of life, but he is aware that he's still at risk of having cancer come back someday. But this was not a decision that was rushed into. It was discussed over and over again, brought to the multidisciplinary group. Radiation oncology was involved, surgery was involved, medical oncology, and all the supportive services that he needed. And with all of this, bringing this back to the group over and over again, and the right time for him, he went and had the benefits of all this therapy. So hopefully he's doing well, and hopefully he'll continue to. So just to conclude, treatment planning depends on stage, somebody's medical condition, and the goal of the therapy. All of these things have to be taken into consideration. And there's no guideline or algorithm or anything that can tell you what to do. You need to look at all of these factors and use your clinical judgment. And the treatment plan requires this multidisciplinary approach between medical oncology, radiation oncology, surgical oncology, and palliative care, symptom management. You're going to hear more about that later, and I can't stress to you enough, for anybody who has helped people with gastric cancer and esophageal cancer, managing these symptoms is one of the most important things. And I think that is it. And I'm happy to answer any questions.
Thank you very much, Dr. Mulcahy, for an excellent overview of how we apply our treatments based on the guidelines. And also note, some of our panelists are a little bit under the weather today, and so we really appreciate all of them coming, and especially Dr. Mulcahy and Dr. Posner, Sniffles 1 and Sniffles 2. And so there are a number of questions here. If you have any questions, please flag down in the audience, flag down the people with the microphones. But in the meantime, I'll read one off the WebEx. How is performance status measured, and is it a subjective measure?
Oh, that's a great question. So performance status, there are a lot of different scales for performance status, and I think one of the easiest ones is called the ECOG performance score. And essentially, we look at how much, the quick and dirty one is how much time are people up and around? How much of their waking hours are spent out of bed? Because we know that if people are spending more than half of their waking hours in bed, these therapies are going to be hard. So it tries not to be subjective, but it is somewhat subjective. How much time do they spend at rest during their waking hours? What do they do? Do they get out of the house? Are they active? Are people sedentary? And there's a lot of things that play into this. So there are some very clear guidelines that we have to try and assign performance status, but it's not a perfect science.
Okay, and a follow-up to that is when you mentioned something about 5-FU basically being able to be given as an IV or oral medicine, the question is, what is the decision process for using IV treatment versus oral therapy?
Well, there's a lot of things. One, if somebody has an esophageal cancer, a mass in the esophagus or in the stomach, sometimes the last thing they want to do is take any more pills, and they actually prefer the IV form. If that IV form, as many of you may know, often involves this pump that you carry around, and lots of people don't like the pump. So as far as efficacy, as far as how effective it is, they're essentially the same. It's really looking at what is best for that person. Now, when I'm giving combinations of chemotherapy, when I'm given the 5-FU with other drugs, I'll frequently use the IV because I think it's better tolerated than the oral in these combinations, but not always. So they're both equally effective, I think. I don't know if anybody has any other opinions, but it's really personal preference, tolerance, and side effect profile, what the side effects are.
And this is a key example of how we use guidelines and all the different choices and then apply to what it might be best for the patient in front of us. And I think of it sometimes as a cookbook. We're the chefs, but the chef has some nuances and some expertise that they use, and they apply it to that specific scenario as best as they can.
We're not as cool as chefs.
We're not cool as chefs, but I try to think
Speak
that
for
way.
yourself.
Yes, sir. We've got a question.
Oh, question.
Are all these protocols followed by most hospitals, or they are just the teaching hospitals that these protocols?
So I should let Al answer this, because that's the beauty of these guidelines. These guidelines are followed across the world. And in these guidelines, we spell out what is the preferred regimen. So anybody can pull these up, and they can look at what are the guidelines. So for the most part, I'm a strong proponent of second opinions, and you can go get second opinions. And I always want people to understand what they want out of that. Some people are reassured when they go to a second and a third and a fourth opinion, everybody's telling them the same thing. That's good, you're confident in what you're doing, but then sometimes it's also good if you go for another opinion, they've got something new and exciting. So there's a lot to be gained from other opinions, but for the most part, these standard treatments, they're proven, there's data, they're used across the world.
Yeah, as an example, last year there were 6 million hits on the NCCN guidelines. So they're widely used. And you now in publications of clinical trials, they all include the guidelines and what standard of care is as a reference. So they're certainly integrated. Now, we want people to use them more and more, and it's not totally universal, but they are widely available. And that's why we feel it's important for patients and their family members to understand guidelines, that they're available, because they can inform the discussion that family and the individual has with the medical team.
Are there any other questions? So I have a question while we're waiting. You mentioned, Dr. Mulcahy, about giving chemotherapy either before or after, with or without radiation, after a surgical case. Can you explain a little bit what the rationale of that is for families and patients? Why do we do that as opposed to just surgery?
So we know with gastric cancer that there's a high risk of recurrence after surgery. And in the past, somebody had a gastric cancer. If there was no reason not to operate, we operated on it. And over time, we frequently saw it come back. So people started giving chemotherapy and radiation after the resection to try and eradicate any cells that might be out there. Because when we talk about cancer coming back, it's not coming back, it was always there. It was cells that were left out there that couldn't be seen. They couldn't be seen by the surgeon, they couldn't be seen on a scan, there was no way of knowing, but they're out there. And we know that there's a higher risk of them being out there if there are tumor cells found in lymph nodes. So we started treating people who had gastric cancer removed with chemotherapy and radiation. And over time, it took a long time, but we were able to show that people who got surgery and then chemotherapy and radiation, they were more likely to be cured than people that had surgery alone. So that became the standard of care. It's hard. Anybody who's had their stomach out knows, if you can imagine getting chemotherapy and radiation after that, it is hard. So There were other studies that were done, and they tested doing the surgery, giving chemotherapy first. Give a couple of rounds of chemotherapy first, then operate, and then give a few more rounds. Is that going to make a difference? And a study was shown that that made a difference compared to surgery alone. So now there's options. If somebody has an operation, giving chemotherapy and radiation afterwards can eradicate any cells that might be left out there. But also, if somebody has a gastric cancer that's found first before an operation, then one option is to give chemotherapy first, then do the surgery, and then give more chemotherapy after. And both of those have been shown to be better than doing surgery alone for certain stages of gastric cancer. So which one do you do? It's not clear. It's not clear. The radiation is hard after that surgery. So oftentimes we'll try and give therapy first. I think it's better tolerated. But there's some people that, for whatever reason, they need the stomach out. It's bleeding or it's obstructing, and they're not going to do well. So then we end up operating first. So there's no, I don't know what you think, but there's not, as far as doing chemotherapy first or doing an operation first. People try and make decisions based on whether it looks like there's lymph nodes involved or what different characteristics about what's going on, but we don't have clear data. That's clinical judgment. What's the best thing for that person at that time?
We have a question here in the front.
If you have a stent placed in your esophagus, are you still able to get radiation after you've had that stent placed? And if so, if you are able to get radiation, does that mean chemo stops?
Can you repeat the question, too?
Yeah, so the question was, if somebody has a stent in their esophagus, can they still get radiation afterwards? And do you have to stop the chemotherapy to do the radiation? So if somebody has a stent because there was blockage, they have a stent, and then the tumor starts to progress through that, you can do radiation. There's debates as to whether there's more risk by doing it if there's a stent in place, but you can give radiation to control symptoms. And it's really you need the expertise of the radiation oncologist and everybody involved to help make that decision. Can you get chemotherapy? You can give chemotherapy, certain chemotherapy drugs with radiation safely. We frequently give 5-FU with radiation, and that can be done safely. Giving other drugs with radiation, some of them are higher risk.
Taxol, for instance?
Which one?
Taxol?
Taxol?
Taxol.
Yeah, so Taxol can be given with radiation at a lower dose.
And to follow up on some of that, one of the reasons why there's lack of consensus as to which approach that we do around the time of surgery, whether it's chemo before and after, or whether it's go to surgery first, then chemo after, or chemo radiation after, is that all of the big trials that help us define the guidelines, we're comparing to surgery alone, not to each other, these different strategies. And so that's why all of these strategies are options, because they were all better than surgery alone. So there are a number of trials ongoing currently that are enrolling patients as we speak to give us the answers that we really want to know now is which of all those options are best, if there is one. They may be equivalent, but now we're going to test that. So that's how clinical research works, is in increments to help us guide us and evolve our guidelines, like Dr. Benson mentioned. So are there any other questions about this particular setting? Okay.